Welcome to the sixth topic of 8 in Section 3, Unit 1, Pathophysiology of Common Injuries and Dysfunctions. In this tutorial, we're going to cover various injuries based around the lower limb and hip. A couple of these are very common and I will point them out as we go along. Starting with an Achilles rupture. This is a grade 3 complete tear. The Achilles is the strongest and most powerful tendon in the body and is constantly under a great deal of load. As you are aware, it is the tendon for the gastrocnemius and soleus. This is the most common ruptured tendon, and guess what? You're not going to be treating this. Again, later on down the line, and also to deal with the inevitable secondary compensatory issues, your skills will be of benefit. I've worked with a professional athlete that while training their Achilles ruptured and it sounded like a gun going off. This is incredibly audible. Other signs and symptoms are loss of range of movement, so that would be plantar flexion, extremely painful, history consistent with possible cause, palpable bunching of the Achilles and a positive Thompson test. To be honest, it's going to be pretty obvious. The possible causative factors include pre-existing abnormalities or weaknesses in the tendon, degeneration of the tendon. This could be caused by a bone spur, for example, rubbing on the tendon. Previous less severe injuries, so somebody that suffers regularly maybe, and then treatment like injections which can damage the tendons. Excessive forces applied to the tendon and ischemia. Talar dome lesions. This is damage caused to the cartilage of the talar dome. This will normally be an impact injury. The damage can happen to various areas of the dome depending on the cause of the injury. This can potentially cause issues with dorsi and plantar flexion movements. In some cases, bits of cartilage will float around the joint, causing further issues such as locking. Signs and symptoms for this condition will be a history consistent with probable cause, pain on palpation, pain under the lateral malleolus on plantar flexion, or under the medial malleolus on dorsiflexion, depending if the injury site is consistent with one or other side. There will be pain in the subtalar joint on these movements. Sense that the ankle joint is catching or sticking, or on occasion it might sometimes lock. Weight bearing will increase the pain and the swelling. Possible causative factors include previous ankle injuries, impact or trauma to the ankle, or it could be a genetic problem. Treatment for this will be physiotherapy and or podiatry, non-steroidal anti-inflammatories, or potentially surgery. Not one for the sports massage therapist at the start, but potentially there will be compensatory issues that we'll need dealing with later on down the line. Plantar fasciitis. This is an issue I see commonly and can be really frustrating for your client. This is when the plantar fascia is overstretched and becomes damaged. Signs and symptoms for the condition are pain on the plantar fascia, normally originating around the calcaneal. This is at its worst first thing in the morning or when you have been sat for some time and start to move again. It will feel like a hot poker in the bottom of your heel. Aching on weight bearing, which will lessen over time. Tenderness on palpation. Pain can increase with heavy activity or long periods of standing, but will generally ease with light exercise. There may be pronation of the foot and tight plantar flexors. The possible causative factors include heavy repetitive landing, so something like netball, recently starting new exercise on a hard surface, poor posture, overpronation during the gait cycle, inappropriate footwear, and can be exacerbated by tight plantar flexors. There is a fair amount that can be done for this injury, including massage of the foot, but especially through the lower leg. The client can also do a great deal, including icing with a frozen drinks bottle, eccentric loading exercises, looking at the footwear and altering exercise patterns. Runners should get their trainers checked to ensure they have the right ones. This is a good one for a guidance sheet. If this fails, which in most cases it doesn't, physiotherapy or podiatry is the next step. where orthotics splints are an option and medication may be employed. Iliotibial band syndrome is another common issue and is generally easily treated. The IT band is a band of fascia that runs from the gluteal fascia at the ilium and the tensor fascia latae muscle to the lateral border of the tibia. Let me point out here the iliotibial band, the ITB, is supposed to be tight. It's a supporting structure, supporting the hip and the knee, and it's not always the ITB that's the problem. Often the vastus lateralis beneath the ITB can be the problem. As the knee moves into flexion, the ITB passes over the lateral condyle of the femur. This repetitive movement can lead to inflammation. This condition is quite common in runners. The signs and symptoms are pain on the lateral condyle of the femur, a positive Thomas test, and a positive Ober's test. I've only ever seen one positive Ober's test on all the students I've ever tried it on. Pronation of the foot, internal rotation of the knee, and an anterior pelvic tilt. Again, a fair amount can be done before a physiotherapist might be required. I often find massaging glutes, TFL, tensor fascia lata, ITB and vastus lateralis has a big impact on the problem. Looking at the client's footwear, running style and running volume is very important. Stretches or a foam roller can be used here as well, whichever you think is going to be more effective. Snapping hip is when there is friction between the greater trochanter of the femur and the TFL-ITB complex. The glute max, TFL and ITB can become tight, and the ITB can also adhere to the vastus lateralis, causing the structure to rub. This is very similar to the iliotibial band syndrome, just the opposite end, so treatment will be very similar, although I don't see this as much as ITB syndrome. This issue can be caused by other tendons, so if the issue is felt more anteriorly, it can be either the iliopsoas tendon or the iliofemoral ligament. Either way, friction is created, causing pain and swelling. Signs and symptoms are an audible click in the hip area with or without pain, discomfort on palpation of the affected structure, and a positive Ober's test. If the pain is felt intra-articular, or if the treatment doesn't help, then there could be something else going on within the joint. That needs investigating further. This could be anything from a damaged labrum to floating bodies. In this case, clients should be referred to a medical practitioner. Osgood-Schlatter's disease is a condition that only affects about 15% of very active children between about the ages of 12 and 16. Once they have stopped growing, the condition will resolve itself. When we grow, the bones grow first and the muscles follow on. Often this is the cause of pain during growth spurts. When the quadriceps are put under pressure from sport and growth spurts, this can cause a lot of pain on the tibial tuberosity as the muscle pulls at the insertion. The signs and symptoms for this condition are pain on the tibial tuberosity, heat and inflammation, and an enlarged tibial tuberosity as the bone is still soft and is stretched as the muscle pulls it. The other important sign is the client's age. Possible causative factors are growth spurts, excessive exercise, tight musculature, and poor diet. This is another one that can be treated, probably more to manage the condition than to completely resolve it. Ice on the tuberosity will help with the pain and looking at how the client can change their activity but still keep doing it. Massage can help to loosen the quads and often stretching is recommended, but it is hard to stretch very tight muscles and can potentially put pressure on the attachment site. The last one in this section goes under several names, including patellofemoral pain syndrome, patellar malalignment syndrome, or runner's knee. This is common in the younger population. This is where the posterior surface of the patella becomes damaged or irritated. The patella normally runs very smoothly in the femoral groove, and the patella is kept in place by the fine balance of the quadricep muscles. If there becomes an imbalance within the quads, Weaker or stronger, the patella can be pulled off its course, and the patella will start to rub the femoral groove, irritating it and causing pain. The factors that can alter the muscle balance are excessive foot pronation, a wide Q angle, and tightness in the iliotibial band or biceps femoris. Signs and symptoms are anterior knee pain, visible maltracking of the patella, atrophy of the vastus medialis, and possible knocked knees. The possible causative factors are muscle imbalance, poor posture, genetics, excessive Q angle, weakness in the vastus medialis from injury or sport-specific activity. Massage can be beneficial, but you also need to understand the cause. Sometimes massage is enough. For example, the imbalance could just be an over-tightening of a muscle that once released is fine. Other times an underlying cause needs to be addressed. This can be as simple as an appropriate rehab exercise readdressing the imbalance. I have seen all of these conditions except for talar dome lesions. You will get a lot of clients with these issues, so take time to understand them. You have now completed this section of pathophysiology of common injuries and dysfunctions and can complete the quiz, and then move on to the next section.